Yes, yes, yes.
Good evening, everybody. It gives me great pleasure to welcome all of you for this very wonderful webinar from Thane ISA. Today, I put a flyer everywhere about one line which we anesthetists always think of: "Be still, my beating heart." It was a very famous song by Sting in the 1980s. And this statement is used in various forms by many poets and writers, because if your heart is still and beating steadily, you can achieve a lot of things. Especially in the OT, when a patient is having some arrhythmia or something is going up and down, we need to be calm ourselves to tackle the situation. And that is the essence of today's webinar. I'm very happy to welcome all of you to this webinar. We have great speakers, all of them are teachers, so they will have a lot of experiences to share with us. I would like to welcome our moderator, Dr. Supriya Gajendra Gadkar. She's been my senior at LTMMC and I've learned a lot from her. She's a consultant at PD Hinduja Hospital, Mahim, for the last 25 years. And her special interest is cardiothoracic anesthesia, which is why she's like the core member today. And I'm sure it will be a great discussion. So without further ado, I request Dr. Supriya to take the scientific program ahead.
Thank you so much, Manisha, for your such kind words. Thank you, Manisha, Parna, ISA Thane branch, and SAMS for giving me
Supriya,
this
you are
opportunity.
muted, I think. Please unmute yourself first.
No, can you hear me?
Yes, yes, we
Yes.
can hear you, ma'am.
Yeah. Thank you, Manisha, Parna, and ISA Thane branch and SAMS for giving me this opportunity. Today we have three great talks and very, very accomplished speakers. So our first speaker is Dr. Pallavi Vaghalkar. Dr. Pallavi is an additional professor of anesthesia at St. GS Medical College and KEM Hospital. Her areas of interest are BLS and ACLS training, academics and airway. She is also a ISA Mumbai Metro EC member, MUHS, UG and PG teacher, and a AHA certified instructor of BLS and ACLS. I invite Dr. Pallavi to give her talk on patchy upper extremity block in high risk patient. So over to you, Dr. Pallavi.
Thank you, madam. At the outset, I would like to thank Thane ISA and SAM's office bearers for giving me this opportunity. I'll be straight away sharing my screen with my today's presentation about patchy upper extremity block in high-risk patient. Greetings from my institute, St. GS Medical College and KEM Hospital, Department of Anesthesia. My case was 52-year-old female presented with a history of fall, and she complains of pain and mild swelling in the right hand. There was no significant history of LOC, vomiting, convulsions, or ENT bleed. She had history of hypertension and diabetes since 10 years and on medication, controlled. General examination and lab investigations were normal. Airway examination, mouth opening was only 2 fingers. She was chronic gutka chewer. So the airway was difficult. So we were worried about the GA. She was posted for distal end radius, open reduction and internal fixation with plating. The case was induced under USG guided right axillary block, which was given by second year resident in anesthesia. Drug given were injection bupivacaine plain 0.5% 8 cc and lignocaine plain 2% 7 cc. So 15 cc was given at the axillary approach. After 15 minutes, patient felt that hand was heavy and numb, but she was wincing on pressure at the deep fracture site at the distal end of radius. So, before proceeding for surgery, we decided to give a USG guided repeat injection of local anesthetic by axillary approach only. It was given only at the radial nerve site and was given by the lecturer with the injection of lignocaine plain 2% 5 cc. Even after this repeat block, pain was there at the deep fracture site. So we asked surgeon to infiltrate injection lignocaine 3 cc at the fracture site again before starting. Even after doing so, patient had some pain at the surgical site. So we gave intraoperative sedation in graded manner, injection fentanyl total 150 microgram, and injection midazolam total 2 milligram. Even paracetamol was given 1 gram IV. Tourniquet was also applied intraoperatively, and the total tourniquet time was 1.56 hours. Procedure was over, recovery uneventful, patient vitals were stable. And post-op, patient started moving her fingers, but pain was there still at the fracture site. The complete recovery of block was at 9 p.m. same day. We induced the patient at around 12 p.m. So basically, what are this was like a patchy block or a failed peripheral nerve block. So let's navigate through this failed peripheral nerve block and understand the reasons of failure on methods to reduce the incidence of such kind of cases. So I referred to a journal in a BJA, British Journal of Anesthesia, in 2023. Article defines the block failure as a block that does not provide anticipated level of anesthesia or analgesia with adequate time frame to allow the planned procedure to take place with adequate patient discomfort without the addition of further unplanned interventions. Now, unplanned interventions like additional nerve blocks or systemic analgesia or sedation or general anesthesia. So, basically, in this article, the block failure incidence they have given is about 1 in a 10 peripheral nerve blocks. They might not be effective. So that was a audit in Australia where they studied 7,000 blocks, where they found that in 1 in every 10 blocks can be inadequate. So what are the mechanisms? In this article, if you see what are the mechanisms and what are the factors, there are patient factors, surgery factor, and the anesthesia factors. So patient factors, basically, patient can be anxious, or the patient will not be compliant, or obese patient, which can be difficult in anatomy. Some patients can have difficult positions, and there will be anatomical variability. Surgical factors like approaches or tourniquet, anesthesia-related factors like inadequate experiences. So let's revise. Patient-related factors, basically, some patients can have a language barriers. They will not understand. We have to really explain to them very well how the block is given and what kind of anesthesia they'll have. Some patients who have altered mental status also can affect the understanding and compliance. Anatomy related factors are patient is obese. So the approach of the block, the anatomical, the view of the target, it will be difficult. So we might have to choose our probes, our positioning, our assistance very wisely. Sarcopenia will make the nerve identification difficult. Some patients with trauma or arthritis, the position, adequate position for block itself can be, difficult in these patients. And physiological factors like some of the conditions like Ehlers-Danlos syndrome, where there is hyperflexibility and because of the mutation of the sodium channels, they will be resistant to the local anesthetic. So in that case, we can have a patchy block. Anatomical variation, as we know, the brachial plexus itself will have a lot of variations. The pre and post fixed plexuses are different. The spread at different approaches, different levels is different of the drugs. The terminal nerves, if you go more and more distal, there'll be high variability. Some of the patients have been shown that there is absent musculocutaneous nerves. In lower limb also, there is a complex knee innervation and femoral nerve variability is seen. Some of the patients who might have artificial variations, some like tattoos or implants like revisions or pacemakers, they will make your approach difficult. They will obscure the views. And sometimes we are also worried about the approaches because we are worried about the infection at these sites. So there'll be a patchy block. So coming to surgical factors, so what are the surgical factors? Sometimes you have chosen some block you have given and the surgical plan changes. So now there is alternate approach taken by a surgeon. So that block can be ineffective. There might be a duration mismatch. That procedure length, has exceeded the block duration. Or there could be a tourniquet pain. Tourniquet pain is a complex mechanism underlying it, where whatever block you have given, that might not be effective to relieve the tourniquet pain. And the factors like communications, and you really have to be friendly with your surgeons to discuss with the plan with them, surgical as well as anesthesia plan with them. Anesthesia related factors will be As in our case, the first time that block was given was by a resident who was learning. So there is a lot of learning curve, even for the experts. With the USG guided approach, we need to have a lot of adaptation and learning curve for this proficiency. So always senior support is crucial. The equipment, familiarity with the ultrasound and the needles is essential. If we choose a local anesthetic, the inappropriate agent can lead to a slow onset or inadequate duration. So, or sometimes most of them, it can be very prolonged block where the patients are posted for a daycare surgery and we just get a prolonged block. So, the local anesthesia choice is also very important. So, all these factors, if we have to consider, the block room model where there is a dedicated space is there for a block, which will improve the teaching and efficiency is advised. And also the ultrasound optimization is advised. So this article in BJ has given the factors and the mitigation strategies. Like patient-related factor, if patient is anxious, again, we have to take a proper consent, inform the patient about the procedure, have a adequate communication, give any leaflets or interpreter if needed. If this patient is obese, then the choice of block, the choice of USG probe, sometimes you have to have a curvilinear probe, but then the resolution will be affected or experienced clinician will be required. Positioning difficulties, like if you have this difficulty in giving position, your assistant should be good. The choice of block again matters. Then the Ehlers-Danlos, as we have already discussed, so we should take a detailed history of the patient. Anatomical variability, we should be always having a prior knowledge of this variation and always try to do pre-scan so that to find out any variabilities are there. In surgical approaches, always have a team brief with your surgeon so that what is the surgery, what is the plan, if the backup plan should be there if the block fails. Tourniquet pain can be taken care with IV analgesia or think about additional blocks. For anesthesia-related factors, as we have seen, there is a lot of training and senior support. Get familiar with your equipment. You choose your local anesthetic wisely. And USG optimization, like correct probe, mode, preset, gain, depth of the USG, and part, that is a mnemonic which is used for optimization, will see to it that. So this article also gives the ultrasound optimization pathway also. Like if you have to optimize the block performance, so your first of all equipment should be adequately maintained. There should be correct needle, correct length, gauge, and ecogenicity. Your power source to the equipment should be connected. Then your ergonomics should be clear, where the patient should be positioned, table height should be proper, and operator, patient, and the screen should be in line. Your assistant who is helping you should be familiar with the equipments, and we should discuss your plan of regional anesthesia with them also. Then comes the visualization on USG. They say that prep, stop, block. Prep means you prepare everything, then stop, take a breath and think that whether the preparation is proper, what approach, what is the surgery. Think about it and then go for block. Always pre-scan, choose correct probe, mode, preset, gain of the image, depth we have to set. And angle of insinuation by the part, that is a procedure for USG probe. Always, if you have to identify vessels and include that, go for Doppler. So these are the ultrasound optimization techniques they have advised. So this is like a positioning of USG PNB where the operator, assistant, USG screen, block site have to be, the ergonomics have to be in place, and the the target should be in front of your eyes. It should be in line. Whenever you are choosing a needle approach, whether the needle should be across your visual axis or it should be along your visual axis, that has to be decided. That can be done with a lot of practice and a lot of blocks we can give. As if you give more and more blocks, you will understand what you are comfortable in, what kind of approach. Whenever you are doing this USG guided block, you see what you look for and you look for what you know. So if you know the detailed anatomy, then we can go ahead safely. This detailed anatomical knowledge is quite essential in any kind of regional anesthesia blocks. In cases of block, when we give USG, know your key landmarks for the blocks. Now, sometimes the nerves can be very difficult or hard to see on the ultrasound, but we can look for the signposts, which are the constant anatomical relationships, like muscles or surrounding vessels, like bone. like in IJV insertion, carotid is there for axillary block, axillary artery. We can look for those signposts initially and then go for the nerves. Once we have an image, now what? Now we get the image, we have to optimize the ultrasound image also. So what is the frequency of the probe? What is the depth? At what depth is the image? Then we might have to change the gain, focus the image, or press or tilt the probe depending upon the image which is there. So that is a TARP or a part mnemonic. This is the different kind of movements the USG needs to be done. The T is tilting to optimize the image. A is alignment or the sliding of the probe. R is rotation of the probe. And P is the pressure on the probe. So these are the different movements which will give you the optimized image. Now pressure when you give, sometimes you have to give very light pressure in cases of IJV insertion and all, where the vein should be visualized properly. Or in the axillary block, we have to give quite a lot pressure so that the vein can be collapse and only artery will be visible. So that was part mnemonic. If the vision is there, then we have to plan the approach, like from where I have to go, put the needle, from the very close to the probe or keep a 1 centimeter distance and then put the needle so that it will hit the target. So that has to be seen. Also, the techniques sometimes the vessels are coming in between or the nerves cannot be visualized. First is to, instead of going intraneurally, do this half a ml of rapid puff of hydrolocation, locate the nerve first by just injecting saline. And you will be safely, injecting instead of injecting intraneurally or intravascularly. Then there are some papers like the C kind of spread of the local anesthetic in the median and ulnar nerves. And versus non-circumferential spread, the circumferential spread has found to be having the more complete sensory and motor blocks as compared to non-circumferential. As you can see in this, the circumferential uh, approach, whether we can have a complete block rather than having this longitudinal approach. Then, so these are different kind of having a optimized kind of visions or the images in cases of ultrasound guided blocks. Now, any success of peripheral nerve block, we have to have a right drug, right dose, right place, and right patient and right kind of surgery. So what do you mean by right drug when we use we should know the drugs which are where the onset is too slow, like lidocaine and mepivacaine, or the duration will be short in these cases, lidocaine and mepivacaine. But the bupivacaine, ropivacaine will have a good, duration of block. So these are the studies, this was the study where infraclavicular and supraclavicular approach was given and 35 ml of 0.5% ropivacaine was given. And not all the nerves you can see that the block was achieved only after 15 and 20 minutes. So rather than with any of the block, any kind of approach is there, the duration, like the onset was for 15 minutes. So you have to give a adequate time for block to be achieved. So this block room ideas, so there is a dedicated space. We can, prepare the surgical site. We can have pre-scanning. And also we can start the intraoperative sedation where the patient can be calm and cooperative and for the block. So this is the block room, separate room for the induction we can have. Also, what about the mixtures? Sometimes there is a discussion about lignocaine, bupivacaine, whether to have the mixtures or not, so that we can have a faster block. So there have been studies like where they have used mepivacaine plus bupivacaine and only bupivacaine. And if we see the onset of only mepivacaine was obviously faster, but mepivacaine and bupivacaine onset combination was more than bupivacaine. But duration of this combination or the mixtures, if we see, for prolonging the duration of the block, the mixtures were not that useful because mepivacaine, the duration was short. Mepivacaine plus bupivacaine was not that longer as compared to the bupivacaine only when was given. We had a longer duration of block. This is another study where onset times and duration of analgesic effects of various concentration of local anesthetics was used with a standardized volume in a brachial plexus block. So here they use the 15 ml of lignocaine and bupivacaine combination. For every patient, they give 30 ml. This was lignobupivacaine 1:1. The second was only bupivacaine with saline. The third was only lignocaine and saline. And the last was bupivacaine and lignocaine in 2:1. The bupivacaine was higher. So in this case, they found that basically onset was with lignocaine, if you see, even onset was not that very fast as compared to other drug combinations. But duration of action of block was significantly more in only bupivacaine group. The lidocaine does not shorten the onset times if you add with the bupivacaine, but it significantly decreases the duration of action of bupivacaine when it is used in a mixed solutions. If we add the lignocaine with bupivacaine, the block will be shortened. It will have a good quality of block, lidocaine, but the excellent kind of block will be with the other combinations. And bupivacaine without lidocaine has the longest duration of action to achieve the longest postoperative analgesia. So we should decide depending on our practices that whether we should use mixtures or not, or go for a single drugs. The article which I referred to, the British Journal of Anesthesia, the strategies for this kind of repeat blocks, we should always, the think about the last, that is local anesthesia toxicity, and think about the toxic doses. And deeper blocks, if we try to give, we should be always be worried about the vascular punctures. So this British General National Formulary states the maximum bupivacaine dose which can be repeated every 3 hourly, and it should not exceed 400 milligram in 24 hours. So that much should be the bupivacaine toxic dose. So whenever we are giving these repeated blocks, always be worried about the toxic doses of the local anesthetics. So that was the drug and dose. Now about the right place, as we have ultrasound, now initially we used to give the block with the paresthesia techniques or the nerve stimulator techniques, where blindly we used to inject, and we used to inject a more volume basically. Even interscaling we used to use 30 ml, but now we are going ahead with the smaller or volume blocks for the interscaling, as we have to avoid the phrenic nerve. So ultrasound guidance has really reduced the minimum effective dose. We can really, if we see the good image and good, we are near to the nerve, we can give a lesser volume of drugs. They used to think that intraneural injection can be effective, but it is not advisable because intraneural injection has chances of nerve injuries are there, and we can get a very long kind of block, which we don't want. So basically, injecting in a paraneural compartment is the advisable thing instead of giving intraneurally, because safety versus efficacy will be always have a higher weightage. So close enough to the nerve, but not too close to the nerves we should target. As in this picture, we can see the C, where the intraneural and intravascular injections we have to avoid. And perineural injection or intraneural extravascular injections also can be given. So all these nerve plexuses which are there, we should try to hit the paraneural fascia around the every nerve instead of going inside the nerves for the safer blocks. So that's the right place. For the right place, we can use the peripheral nerve stimulation, the proper probe, or you can have a commercial pressure monitor. Nowadays, we are available. Combination also we can be used. After right dose, drug, and place, now right block for the right surgery is the success key. So for that, accurate anatomical and surgical knowledge is essential. For upper limb, the brachial plexus anatomy variation should be known. What is the surgery? Where will be the incision? Whether the surgeon needs the intraoperative, this flexion of not this motor integrity detection, or whether surgeon needs postoperative pain and catheter required. So all these things have to be discussed. Also, we should be aware of, yes, there will be missed segments in an incomplete block. Like even if in the axillary block, the median nerve in quadrant of 1 and 8 in 56 patient, we know that median nerve will be at the 10 o'clock position, but in every patient, it might not be like that. We can have some kind of variation in a normal axillary block also. So we should be aware of these missed segments. So whenever the patient we are giving and having a pain free, we should know that pain is coming from skin, muscle, and fascia and bones. So knowledge about dermatomes, myotomes, and osteotomes is essential. For the upper limb, we should know the cutaneous sensory distribution. We can see the lateral part of the forearm is by the musculocutaneous nerve at the lateral antebrachial cutaneous. By the medial part, major part is by medial antebrachial cutaneous. So if you give work proximally and this part is, spared, we know that maybe this nerve is not got blocked properly. Also, by this knowledge, we we know that if the surgery is at the wrist or the carpal tunnel surgery, you should know that this part of the hand is being supplied by part of ulnar nerve, median nerve, and superficial branch of a radial nerve. So we know which nerves to be blocked. Also, the knowledge of osteotomes and myotomes, which response should be elicited if we are using a peripheral nerve stimulator. Like for the radial nerve, finger extension or especially thumb is important. Like this rock and paper scissors game you can play or ask the patients, where when the rock movement is the action of median nerve, paper is the radial nerve, and scissor, that is action with the index finger and the middle finger, is ulnar nerve, and OK is anterior interosseous nerve. So these are the assessment techniques. This push pull, pinch push pull for the median nerve, and pinch on the ulnar and the radial nerve. So the assessment should be done properly during that 15 minutes after the block has been given. This is a paper which shows the cutaneous innervation of the hand, where the volunteers were given radial nerve, median nerve, and the ulnar nerve blocks. And they studied the intra and the inter-individual variability. In the picture in the hand, the shaded area is not supplied by any of the nerves. And there was a higher variability observed in a radial nerve. There were a lot of variations when they were given radial nerve block. Different volunteers have a different area blocked. So these non-innervated territories can be supplied with the lateral antebrachial cutaneous posterior and the medial antebrachial cutaneous nerve. So the cutaneous nerve blocks also we should be aware of for the upper extremity, because some of the surgical sites are partially innervated by the sensory nerves, which are not part of the brachial plexus, and they're not consistently anesthetized by the brachial plexus block. Like example can be supraclavicular, suprascapular, and intercostobrachial nerve, the T2, which comes out of the brachial plexus. So this has to be blocked when there is a tunicate pain is there. Selective anesthesia, when the block of the entire brachial plexus block is not necessary. If the surgery is at the distal limb, the entire brachial plexus block proximally blocking and then biceps, so the complete motor block might not be necessary. So that time we can block this cutaneous nerve at the elbow or other wrist. And also supplementing the incomplete blocks. It's a controversial indication by selective nerve blocks, supplementing the incomplete brachial plexus block. But whenever you are hitting a single nerve, beware that there is a potential risk of injuring the nerve when you are giving the direct block. So intercostobrachial nerve blocks, we know that 5 ml of local anesthetic subcutaneously along the axillary crease for relieving the tunicate pain, and also for the anterior arthroscopic port insertion is very useful. This lateral antebrachial cutaneous and a medial antebrachial cutaneous. Lateral is the branch of the musculocutaneous innervating the lateral, and the median is for the medial cord. So these are without USG guided. In the literature, there are USG guided blocks also. But these are very safe ones where only the cutaneous or the intercondylar line, we are superficially injecting the local anesthetic, which are without any serious complications. So this can be added in the normal brachial plexus block. So key aspects for deciding the block we should be always discussing the X-ray of the forearm, skin incision, duration of surgery, tourniquet use, and whether the patient is going home directly on the day of surgery, so that we should not have a prolonged block. So we have also referred to a lecture by Dr. Amit Dikshit, and also in our national CME, Dr. Bala Venkat has mentioned about site-specific anesthesia and analgesia, where the short-acting local anesthetic was given in proximal blocks to cover the tunicate, which is followed by a site-specific isolated nerve block with a long-acting local anesthetic. So the isolated nerve blocks with or without continuous catheters, depending on the surgical requirement, can be advised. So these are some distal nerve blocks which are given with PNS or ultrasound guided at the level of forearm. Individual nerve blocks we should be referring to. Coming to the flowchart which is given for the failed peripheral nerve block. Now we know all these strategies, but if the block fails, then what to do? Now, whenever we have given a block, and if the block is adequate, then we should go ahead with the surgery. But if there is surgery, block is inadequate, and the surgery is started or not, we should see. If the surgery is not started, then we have time, allowed time, doc reassess whether the block is taking action or not. After some time, if the block is adequate, then we should proceed with the surgery. If we, after 15-20 minutes, if the block is inadequate, then we should see whether the local anesthesia has maximum dose has reached or not. If you have not reached the local anesthetic maximum dose, then we can give a surgical local infiltration, or any rescue block or top-up blocks can be given. Now, if that is adequate, then go ahead with proceeding the surgery. If the surgery had already started and the patient is getting pain, now we should assess the pain, whether it is actually a surgical site pain. Then we should ask them to pause the surgery and consider the short-acting opioid. With the opioid, we should also see whether local anesthesia has crossed the toxic dose. If not, then repeat the local infiltration or block. If we have already crossed the local anesthesia toxic dose, then we have to think about the general anesthesia, because we cannot keep on giving the opioids. If the general anesthesia is contraindicated, then we'll have to abandon the procedure, might have to abandon. But if the general anesthesia is easy, then we can go ahead with general anesthesia and the systemic analgesia. Whenever the surgery started and we are assessing the pain, if patient is doesn't having pain but is anxious, then we have to reassure the patient and give conscious sedation if there is no pain. If the pain is because of tourniquet, then we have to pause the surgery and consider the low dose ketamine or pseudo-analgesia like propofol, dexmedetomidine, midas, or with the analgesia. And if patient doesn't have pain, then we can proceed with the surgery. If he continues to have pain, then we might have to add with the general anesthesia. So that was the flowchart given for the failed block. This also I've referred to this Professor Ki Jin Chin for Toronto Western Hospital. He had given excellent videos for the tips and tricks for the success of blocks. So he had mentioned that whenever a successful block fails, which can happen in every 100 patient, we have to set our patient expectations, explain to them that there will be absence of pain versus pressure, reassure them, inspire their confidence. LA supplementation should be added whenever needed. Sedation can be added whenever it is needed. So lesson learned in my case, where initial block was given, maybe if there's a difficult case, then the senior should have given the block. And so maybe the next time when the block was patchy, then we can go for another approach. Like this was axillary approach, we can go with the supraclav approach, or we can go with the distal isolated nerve approach. And also that whatever IV sedation and analgesia, whatever we administered, was luckily it was adequate. But sometimes, we might have to convert it to the GA. So if you don't have to come across this kind of situations, and, when there is a failure and the patchy block, I think the factors to improve success rate will be having a better communication with your surgeons, patients, improvise your techniques with the USG probe, or about your knowledge about local anesthesia and correct duration, and do planning with surgeries. You anticipate the failure and be, ready with any kind of additional blocks or measurement has to be taken. Like in summary, we can think about the ultrasound optimization measures, and managing the block failure will end like we have to identify there is a failure, assessing the block adequacy before incision by push-pull techniques or rock, paper, scissors, rescue blocks, considering the individual nerve blocks and the surgical infiltration, pseudo-analgesia with caution, administered IV analgesics, and whenever required, we might have to convert it to GA if other measures fails. Recognize the failure, have a multimodal approach, and always prevention is the key. And for that, we have to optimize our techniques and the communication. So last, I would like to end with the quote of William Osler, is the father of medicine, that variability is the law of life. We will come across patients every day, which will have a lot of variabilities, which will have a lot of challenges. So to face them, we should ensure the consistent education through the multidisciplinary team. And that will be possible with the webinars like this. So thank you.
Very nice talk, Dr. Pallavi. You have covered in detail about all regional anesthesia for upper limb. And regional anesthesia is fantastic because we are not, hemodynamically, the patient is so stable. But I feel also in emergency, we have to optimize the patient how much ever is possible because we always need to have a backup plan.
Yeah,
Yeah, so the consent for GA also should be taken in all
taken. Yeah,
patients.
correct.
Yeah.
Yeah.
I don't see any questions in the chat box right now. People can write their questions in the chat box. Any questions? Manisha, can we,
Yes, ma'am. We'll move to the, I think,
We'll stop sharing.
yeah, we'll move
yeah.
to the next talk.
Yes, please.
Okay, any more questions, please write in the chat box, then we can just take it in the end. Yeah, thank you, Pallavi. Great talk.
Thank you, ma'am. Thank
Yeah,
you.
our next speaker is Dr. Yogita Patil. Dr. Yogita Patil is an additional professor at St. GS Medical College and KEM Hospital, Mumbai. She has done her fellowship in pain medicine. She is a PG teacher, faculty in pain medicine, and mentor for MUHS fellowships. She is also a secretary of ISA Mumbai Metro branch. She's a founder member of Anesthesia Academic Society and Journal Research and Innovations in Anesthesia. She has 16 publications to her name and written 2 book chapters. She's also a facilitator for simulation and training. So I invite Dr. Yogita to give a talk on perioperative myocardial infarction. Over to you, Dr. Yogita.
Yeah, I'm just trying to move my slides. My internet connection is looking unstable. Mm,
Oh,
Yeah, good evening, everyone. So I'll be talking about perioperative myocardial infarction. So objective of this topic, I feel relevant to anesthetists is understanding the perioperative myocardial infarction, pathophysiology of myocardial infarction, risk factors for perioperative myocardial infarctions, the role of anesthesiologist, how we can prevent this complication, what strategies we can implement to prevent this complication. If at all, pharmacological prevention is practiced from preoperative to perioperative period, and a few special considerations in high-risk patients. And I'll be talking about the guidelines because ACCHA 2024 guidelines are excellent evidence which we can utilize. It has given so clear guidelines about most of the cardiac conditions that we as anesthesiologists should not have any confusion to decide what investigation and wait for when further investigations are required. So perioperative myocardial infarction is a significant 1 minute. Just I'll minimize my toolbar. Yeah. So perioperative myocardial infarction is a significant cause of morbidity and mortality in patients undergoing surgical procedures. Anesthesiologists play a pivotal role in the prevention of perioperative myocardial infarction by providing stable hemodynamics of surgical patient. So this talk will outline about the mechanisms, risk factors, and strategies utilized by anesthesiologists in day-to-day practice. Understanding perioperative myocardial infarction, by definition, perioperative myocardial infarction is referred to a myocardial infarction occurring within 30 days of surgery, and it is identified through a combination of elevated cardiac biomarkers such as troponin levels, electrocardiographic changes, and clinical symptoms. But although these are handy tools for us and even cardiologists, but many cases might be symptomatic due to the effect of anesthesia, analgesia, and nowadays we get so many diabetic patients. So because of that, they may not have the classical symptoms of myocardial infarction. So epidemiology of perioperative myocardial infarction is approximately 3 to 5% of patients undergoing major non-cardiac surgery. And higher incidence is noted in vascular thoracic and emergency surgeries. The mortality rate, oh, 1 minute, my presentation has gone. I clicked some other. Sorry for the, my cursor is not moving. Sorry for the technical. So mortality rate is approximately up to 30% within 30 days, making the prevention very critical. Pathophysiology of PMI is the primary mechanism include in type 1 of perioperative myocardial infarction, plaque rupture, and thrombosis. The rupture of an atherosclerotic plaque leads to thrombus formation and coronary artery in non-surgical settings. Type 2 of perioperative myocardial infarction can be supply-demand mismatch we come across very often during anesthesia. A mismatch between myocardial oxygen supply and demand without acute plaque rupture. So common perioperative factors include perioperative or intraoperative hypotension, which may precipitate the ECG changes and demand supply imbalance. Preoperative anemia or blood loss, which is not replaced adequately, and perioperative low hemoglobin can again precipitate that demand supply mismatch. Hypoxia, because of whatever reasons, persistent tachycardia, and increased sympathetic activity due to surgical stress and inadequate pain management can also lead to demand supply mismatch. So these are the cardiological reasons of perioperative myocardial infarction, but there are non-ischemic myocardial injury conditions such as sepsis, severe arrhythmias. They can be preoperative or intraoperative, develop suddenly. Pulmonary embolism, all these can also cause myocardial injury without direct ischemia, and again they present somewhat similar like myocardial ischemia then. So what are the risk factors for perioperative myocardial ischemia? Patient-related factors are obviously more aged above 65 years of age are known to have risk for perioperative MI. Known coronary artery disease patient posted for surgery, which is a very common scenario for nowadays. Previous history of myocardial infarction, not optimized properly or not on regular medications have obviously more risk. Heart failure patients, chronic diabetes mellitus, chronic kidney disease, hypertension, smoking and obesity are again the independent risk factors for perioperative myocardial infarction. Surgery related risk factors are there are few surgeries like vascular, thoracic, and major abdominal procedures are known to have more incidence of perioperative MI. Again, emergency procedures always carry more risk because there is no time for optimization of these patients. And prolonged surgical duration leads to many physiological changes initially, which gets converted to pathological changes because of hypothermia, maybe blood loss, coagulation is disturbed, and many other things leads to then increased incidence of perioperative myocardial infarction. And again, this intraoperative blood loss supply demand mismatch can precipitate perioperative myocardial infarction. Anesthesia related risk factors, it's not a direct risk factors, I can say, but inadequate depth of anesthesia leading to stress response and probably leading to tachycardia may precipitate MI in patients where there is a very low margin for tolerance of tachycardia. Hemodynamic instability in certain situations when there is sudden blood loss and we are not able to manage the hypotension properly may precipitate MI in the intraoperative period, or persistent hypertension in the postoperative period can precipitate MI in the period or any time in the course of event of patient. Hypoxia in the postoperative period or persistent hypercarbia, especially laparoscopic procedures, we label them as low cardiac risk surgeries minimal invasive surgeries, but being CO2 is used, may precipitate sometime if that CO2 clearance has not happened properly, can lead to perioperative MI. And poor postoperative pain control, patients are never comfortable, they are anxious, they are tachycardic, can again precipitate perioperative myocardial infarction. So, what are the strategies for preventing perioperative myocardial infarction? Obviously, multidisciplinary perioperative approach is the best approach we can use. And as such, we are utilizing for years this strategy. So, preoperative risk assessment, identifying high risk patients and optimizing them if feasible. When time sensitive surgeries are there, we have to take decisions as per that. Intraoperative management is maintaining hemodynamic stability as close to the physiological limits as possible, optimizing oxygen delivery and minimizing myocardial stress and stress response to surgery and pain. Postoperative monitoring obviously ensures early detection of this complication, and prompt management of such ischemic events may give us better outcomes. So these are the broad strategies which we can opt as a perioperative physician to imply. Perioperative anemia management itself, as per the ACC/HA guidelines, is very, very important. Even though we always have learned classically that cardiac patients should have a better HV of around 10, but the studies have shown that hemoglobin transfusion threshold of 8 gram per DL compared to 10 gram per DL shown that no difference in mortality, major adverse cardiac event, or recurrence of a target hemoglobin of 8 or 10. But still, as an anesthesiologist or perioperative physician, we have to take a decision of optimizing the hemoglobin depending on the disturbance in the physiological parameters and the oxygen demand of the patient. So other investigations can be utilized for better understanding of the oxygen delivery to patients. In high-risk patients undergoing lower extremity arthroplasty with history of venous thromboembolism, seizures, ischemic stroke, use of tranexamic acid associated with fewer transfusions without increasing the risk and probably having a better hemoglobin in the perioperative period, which is very, very important in elderly patients. And then we can probably stretch our transfusion triggers to a little higher side for transfusion. So again, I will talk about preoperative strategies. Risk stratification, various indices are known. Generally, we anesthetists use this revised cardiac risk index to assess perioperative cardiac risk. Then identify patients with poor functional capacity who may need further cardiac evaluation, and maybe we need a consultation of cardiologists for all these patients to work further. So broadly, optimization of comorbidities like coronary artery disease, ensure optimal medical therapy with beta blockers, statins, and antiplatelet agent whenever appropriate. Heart failure patients should be optimized for volume status. Their ACE inhibitor should be continued depending on exactly where they are. Non-high risk patients, ACE inhibitors may be discontinued, but ACC/HA guidelines say it can be continued. The incidence of perioperative hypotension or intraoperative hypotension is always there, but heart failure patients, continuation makes sense. Hypertension control is very, very important, and target of even though 140/90 is a dream, but diastolic BP of 90 millimeter of mercury is feasible to achieve in the preoperative period whenever possible. And tight glycemic control in the perioperative period is very, very important, which can be possible to optimize in the patient when there is elective surgery. Again, in the preoperative period, cardiology consultations will be needed in few conditions. So these are those conditions where we will definitely need a cardiology consultation is unstable angina, decompensated heart failure, and in such situations, with consultation and multidisciplinary team approach, we may even defer the elective surgery for some time. And once the patient is optimized, we can decide for posting the patient electively if it's possible. I will be discussing this exactly how we go about it when I will be talking about ACC/HA guidelines in details. Continuation of medications, we all are aware that beta blockers should be continued if they are on, but new or newly beta blockers are not added, and if at all they are added, at least they should be added 15 days prior to the procedure. Statins continue perioperatively for their plaque stabilizing and anti-inflammatory effects. And antiplatelet therapy, we as anesthesiologists has to always take a call of which drug to stop and which to continue. Again, I will be discussing in detail which anticoagulants to be stopped at what time when I'll be discussing about ECCHA guidelines. So anesthesia considerations and intraoperative management, as such, implementation of whatever kind of anesthesia we have chosen, there is no difference between general anesthesia and TIVA, or volatile anesthetics is used with GA and TIVA. So whichever we are comfortable probably and available, we should go ahead with our comfort and our availability, and the setup wise decisions are absolutely okay. No difference between neuroaxial anesthesia and GA, but the most important thing for neuroaxial anesthesia is maintenance of hypotension. We should not allow hypotension at any cost whenever we are planning for neuroaxial anesthesia. Epidural anesthesia is recommended for pain relief in major abdominal surgery. The evidence is 2A. So there is definite advantage of implementing epidural analgesia in the perioperative period. For hip surgery, it is 2B evidence. So it is definitely useful, but if there are alternatives available, we can use the alternatives. So there are hundreds of blocks now around for hip surgeries, and so many new blocks have come across now. So if we are comfortable practicing those blocks for better mobility of patients, especially orthopedic patients, we may implement those blocks and not take a decision of putting an epidural, but epidural has definitely better recommendations. Maintaining of normothermia is very, very vital for preventing the increase in the oxygen demand and other pathological processes which are set in with hypothermia. I mentioned in the previous slide also that tranexamic acid definitely reduces the blood loss. And so transfusion might be reduced, and anemia optimization is very, very important. So even intraoperative target of 8 should be good for non-cardiac patients. Otherwise, fit patients, we may take a target of transfusion of 7. And preoperative iron therapy and anemia optimization has a very, very crucial role where elective surgeries are planned. So what other intraoperative strategies we can utilize? So continuous monitoring of Filey DCG with ST segment analysis. So ST segment analysis can give us actual the measurement of that how much segment it is, that how much is changing. When there are low EF patients or valve surgery patients, invasive arterial blood pressure monitoring is recommended because that gives us bit-to-bit monitoring. Consider central venous pressure monitoring or minimal or invasive cardiac output monitoring for complex cases like vascular surgeries, major abdominal surgeries, surgeries like Whipple's, where or other wherever there is a need of vasopressors as well. There's putting a central line does help for better management of hemodynamics. Anesthetic technique, I already discussed that no other anesthesia technique is superior or inferior. So whichever we are comfortable as per the demand of the surgery, the site of surgery, we can choose regional anesthesia or general anesthesia. So hemodynamic management, maintain the blood pressure. So the mean arterial pressure of around 65 millimeter has to be maintained at any cost. And if we feel that if volume status is good, decision of using vasopressors or adding vasopressors can be taken. And we should avoid wide fluctuations in blood pressure where there is hypotension, then we have added vasopressors, then suddenly there is hypertension for some period. So that is not good for heart as well as even for brain. Optimizing perioperative oxygen delivery is very, very important. Intraoperatively, we as anesthetists, we always give good oxygen delivery to patients, but post-op sometime, once they are shifted in the ward, they may be neglected. And especially elderly patients may have that, or they require that supplementation of oxygen for a better oxygen delivery. Heart rate control is very crucial. So certain conditions we can't afford to have a tachycardia. So there we have to have rate control and having a generally heartbeat or pulse rate of less than 80 beats per minute For that, we can always have a cardiology consultation and beta blocker or calcium channel blocker or other antiarrhythmic agents can be planned. Fluid management obviously is very crucial in the intraoperative period. Avoid both hypovolemia as well as fluid overload so that we are not giving extra load to heart and to pump the heart extra for pushing that volume overload. Stress response modulation is possible to anesthetists because adequate depth of anesthesia definitely blunts the sympathetic response to surgical stimuli. And short-acting beta blockers, if we have hypertensive response like esmolol, may be utilized when there is tachycardia control is required, but long-acting beta blockers are not preferred intraoperatively. So certain surgeries or certain conditions do demand monitoring with transthoracic echocardiography or transesophageal echocardiography or focus is reasonable for unexplained hemodynamic instability. Suddenly, patient was all right and then he has developed a hemodynamic instability. So nowadays, anesthetists are getting trained into focus. So having a probe kept for that and utilizing the focus is very, very important. Temporary mechanical circulatory support may be used to rescue therapy in acute, severe, or hemodynamically instable situation. Routine use of PA catheters is not recommended, so it's a class 3 recommendation. So we are almost going away other than cardiac surgeries for other procedures. So what post-operative strategies we anesthetists day-to-day basis we implement is intensive monitoring. High-risk patients should be monitored in the ICU or high dependency unit with continuous ECG monitoring. Serial troponin measurements for early detection of myocardial injury, particularly in vascular and high-risk surgeries, can be implemented. About this troponin level measurements, whom should be we monitoring? I'll be discussing about when I'll be talking about ACCH guidelines. Pain control is very, very crucial in the postoperative and myocardial oxygen demand. So multimodal analgesia with multimodal drugs like opioids, paracetamol, and even blocks. So blocks can be single shot catheter-based block, which we can utilize, which can give pain relief for 2 to 3 days, is desirable in this high-risk category of patient. And prevention of thromboembolic complications with anticoagulation management is very crucial, especially in orthopedic procedures, cancer procedures, where they have a known complication of thromboembolic phenomenon in such patients. Again, hemodynamic stability is very, very important. They should be started oral fluids as early as possible. If they are not starting on oral fluids, we have to supplement with fluids and avoid hypotension. Sometimes epidurals are blamed for hypotension, but if patients are taking good or we are giving good fluids, probably hypertension doesn't have those complications, but it is it is to be avoided. Hypoxia and tachycardia in the postoperative period, again, so much of stress on tachycardia should be avoided. Early mobilization reduces the risk of thromboembolic complications and promotes overall recovery. And even patient's sense of well-being is improved. They feel more confident. They feel more that they are recovering faster. So minimum physiotherapy, depending on kind of a surgery, making them sit in a bed, gives a better sense of well-being and even mobility of feet and hands at the bed also reduces the thromboembolic complications. So perioperative pain management is very, very important, and there is a very strong evidence that like abdominal surgeries, lower rates of postoperative myocardial injury and supraventricular tachycardias were noted when thoracic epidurals were utilized. And when patients with hip fracture, lumbar epidural analgesia has shown from in high surgical population. So even though we are moving away from epidural, but the evidence is really good for epidurals. But it's a choice of surgical team and anesthetist what kind of a post-op analgesia and blocks we are utilizing in the perioperative period. But patient should be definitely pain-free in the perioperative period. So, a special consideration in high-risk patients, like patients with recent uh, event, so surgery within 6 weeks of bare metallic stent placement or 6 months of drug-eluting stent placement carries a very, very high risk for stent thrombosis when dual antiplatelet agents are interrupted. But if surgery demands, we have to go ahead with cardiology consultation and other take care should be taken for such patients. So multidisciplinary management is very critical. So we should be working as a cardiology, anesthesia, and intensivist and surgeons as a team and managing and taking the decisions about further management of such patients. Elderly patients are definitely high because of risk because of their comorbidities and or typical presentations if they are diabetic. Sometimes they don't appreciate that pain so well, or they feel it's part of their daily problem because of decapacity. So they don't tell us about the exact presentation. So we may miss certain events or small things in elderly patients. So careful hemodynamic monitoring and tailored anesthesia plans are very, very essential in such patients. Patients with chronic kidney disease, uh, the dosing has to be adjusted and monitor for fluid overload is very, very crucial. And this chronic kidney disease patients are inherently for a higher risk of perioperative myocardial infarction. So these three category of patients, we have to be very, very careful in the perioperative period. So I'll be talking about current guidelines and recommendations. So ACCHA guidelines 2024, we have revision of these guidelines. European Society of Cardiology had their last guidelines published in 2022. There are little bit of differences, but American College of Cardiology means ACCHA guidelines are so robust that I feel we all anesthetists should know about it. So I'll be talking about a few important slides about these ACCHA guidelines, which definitely helps us in decision making in the perioperative period. So the goal of those guidelines were to have risk assessment, management strategies, what drugs to be continued, what to be stopped, what to be added later on. And obviously, patient-centered and team-based approach, they insist for perioperative period. And continuity of care is very, very important. So when we talk about these ACCHA guidelines, class 1 is the evidence is very robust. It is recommended that we have to do these things. Class 2A is it's reasonable, can be useful, effective, and beneficial is if it is probably recommended or continued. Class 2B is may or may not be utilized, but there is no harm giving those or no harm in taking those decisions. But class 3 is obviously the risk benefit ratio, there is a risk or harm, so we should not be utilizing those recommendations. Level A, like this level A, B, C is the level A is the trials are done in multiple populations, so they are more robust for evidence. Level B is a certain class of population is only the studies have done, so they may have a variability in individuals having the response of drugs, which is not studied well. Level C is very small population is utilized for trials, so they are not very robust evidence to follow. So definition of surgical timing and surgical risk. Surgery, we call it emergency when we have time less than 2 hours and there is immediate threat to life or limb without surgical intervention. So here there is no question of we saying no, we have to go ahead with the surgery, but we have to take care of the things. Urgent surgery is where threat to life or limb without surgical intervention, when there may be time for preoperative clinical evaluation to allow certain interventions that could reduce the risk of perioperative myocardial adverse events. So we have a typically time from 2 hours to probably 24 hours. So here the role of cardiology is very crucial in taking further decisions. And generally we summon then the cardiology opinion in such situations. Time sensitive surgeries, we call it surgery, may be delayed up to 3 months to allow for preoperative evaluation and management without negatively impacting the outcomes. So, patient with bare metallic stent, maybe after 14 days to 3 months, they can be posted. But drug-eluting stent probably it's a time-sensitive procedure, so we may defer if there is no harm in postponing the surgery. Elective surgery, here there is ample of time to optimize the patient. So better we optimize the patient before taking any decision. High-risk surgeries are aortic and major vascular surgeries. Peripheral surgeries, again, we forget, but then they are classified as high-risk surgeries. Hemoperitoneum, any major intra-abdominal surgery again comes under high risk of surgery. Intermediate risk surgery are carotid endarterectomy, head neck surgery, orthopedic or intraperitoneal surgery. And low risk surgeries are cataract, breast, skin. So here we may not have repeated consultations of cardiology. Whatever stable investigations last 3 months, we can accept and go ahead with the surgical procedure. So here there is a situation, a 60-year-old male patient with history of hypertension for 8 years on medications and history of INT since 4 years. Came for umbilical hernia repair and patient has a ECG done 2 months ago. So should we ask a repeat ECG? This is a common question we get as an anesthesiologist. So the ACC-AHA guidelines recommends that previous ECG is available from previous 3 months, and there has been no intervening change in clinical status. So repeat ECG is likely not needed. We can go ahead with whatever ECG is available. So which cases we should have a fresh ECG is patients with known IHD or fresh IHD, significant arrhythmias, peripheral artery disease, major coronary vascular event has happened, or other significant structural heart disease is there. We have to have a fresh ECG in such patients. Assessment of left ventricular function. Generally, routine preoperative evaluation of LV function is not recommended, but it is reasonable for patients with dyspnea of unknown origin undergoing preoperative evaluation of LV function. So, in such patients, it is reasonable to do. Patients with heart failure, with worsening dyspnea or other change in clinical status to undergo preoperative evaluation of LV function. So, in such cases, we should have a 2D echo done in the patients. And class 2B is where it may be considered like reassessment of LV function in clinically stable patient with previously documented LV dysfunction. We may ask for 2D echo if time permits. If we may not ask for it and go ahead with the surgery if patient is stable. So 2D echo is a static test when stress testing is required. So stress testing is required in patients where there is elevated risk or poor meds, less than 4 meds are available. And sometimes unknown functional capacity, patient is not moving only in the house, or there is a problem of knee, problem of hip joint or spine. In such situation, they don't move. So in such patients, probably stress testing is required, but routine screening is not recommended. So non-invasive pharmacological stress testing can be done if patient is non-ambulatory. So dobutamine stress echo can be done, or other methods of perfusion scanning can be utilized depending on the setup and the type of surgery we are planning and the expectations or expected risk of patients in the perioperative period. So here we may subject the patient for non-invasive pharmacological stress testing. Cardiopulmonary exercise testing is nowadays called as gold standard for evaluating functional capacity. But here again, patient has to be mobile. Patient should be able to perform the exercise. And it definitely helps in diagnosing etiology of that exercise intolerance, whether it's cardiac origin or pulmonary origin. So guiding preoperative optimization and rehabilitation is possible if cardiopulmonary exercise testing is done. But I guess India, it's not very common, but major institutes are definitely adapting to this modality of testing. Coronary computed tomography or angiography is advised in patients where there are less than 4 meds and very, very high risk coronary anatomy is suspected. So I guess cardiologists are the better people to advise us whom we should subject to coronary CT angiography, but it has equally good results with compared to invasive coronary angiography. So sometimes we may subject the patient to computer CT angiography rather than invasive coronary angiography, but we have to have a multidisciplinary team to decide this. So calculation of risk to predict perioperative cardiac morbidity, again, frailty and perioperative biomarkers for risk assessment are very, very important. So revised cardiac risk index here, there are important 6 predictors: high surgical procedure, history of cardiac failure, IHD, stroke, insulin-dependent diabetes mellitus, and serum creatinine more than 2. So when the score, the number of risk factors are more than 3, we can see that 11% mortality event rate is there in the perioperative period. So here in ACCSA guideline, major adverse cardiac events are possible in category of patients. There are multiple factors, they say, to history. So 210 points are allotted to each point: history, electrocardiographic changes, age, risk factors, and troponin levels. So here the risk factors, more than three risk factors of history of atherosclerotic disease. So these 2 points. So this scoring of 0 to 3 point, there is a very low risk of having perioperative adverse event. They say 1.7% risk. But if the risk, the ratio of this event is 4 to 6 points, intermediate risk, so 16.6% risk of perioperative adverse cardiac events. And then the score is 7 to 10, high risk, 50.1% risk of having major adverse cardiac events in the perioperative period. So assessment of functional capacity, again, METs, how we do, or if METs are not possible, how we calculate the functional assessment, because staircase climbing is a very standard method. We use it. So we all are aware of this. The left side chart is showing the metabolic equivalents, but when there are less than 4 metabolic equivalents, we have to have another method of assessing also. So Duke Activity Status Score is a formula which can be utilized, and depending on this Duke Activity Status Index, if that score is more than 34, significantly associated with 30-day death or perioperative MI in patients evaluated by MET study. So this can be utilized. These are the standard formulas. So can be have like a cognitive aids can be kept in operation theater to calculate all this risk. Again, elderly patient, the way I told that more than 65 years of age, they are risk factor for perioperative major cardiac events. So friability is something score which we across multiple systems over a period of time. And this is independent risk factors for perioperative uh, adverse cardiac events. So there are multiple for the scoring system for assessing frailty, whichever people are comfortable can utilize. But if frailty can be improved by rehabilitation, like physical conditioning, better nutritional support, or doing physiotherapy before procedure if time permits, can help to have a better outcome in the perioperative period. So preoperative biomarker for risk stratification. So here we can use the BNP and pro-BNP levels. So pre-operative BNP concentration of around 0 to 99 nanogram per liter, we can see that likelihood ratio for death is around 0.6. And if pre-operative pro-BNP levels are 0, of death or MI is 0.4. And when there is almost twofold increase in the BNP levels, more than 250, the likelihood of death is 3.9. Similarly, if pro-BNP levels are more than 2000, the likelihood of death is 5. So here we definitely need a multidisciplinary team approach for optimizing of such patients. So cardiovascular morbidities and perioperative management. Hypertension has to be controlled whenever possible. Elective surgery, we should be starting the antihypertensives and continuing the antihypertensive depending on the type of medications they are taking. So here there is a case scenario: 50-year male, hypertensive since 6 years, posted for non-obstructive inguinal hernia repair, and his BP is 210 by 130. So surgery is to be deferred. Yes, obviously it's non-obstructed hernia. So here the better BP control is required, and they said antihypertensive has to be continued for 15 days, and then patient can be posted for surgery because it will give better hemodynamics perioperatively and can reduce the complications. Heart failure patients, again, that's a case scenario for 40-year female with history of diabetes since 6 years on tablet, dapagliflozin and metformin with HGT of 120 milligram per DL, posted for deviated nasal septum repair. So how many days prior should this SGLT2 be stopped? So ACCHA guidelines say that at least 3 to 4 days prior, these SGLT2 inhibitors has to be stopped for better metabolic acidosis control and better sugar control. But in case of compensated heart failure undergoing non-cardiac surgery, it may be reasonable to continue the guideline mediated medical line of treatment, excluding this SGLT2 inhibitors in the perioperative period. Coronary artery disease, again, there is scenario. Suppose take it that patient is acute coronary syndrome and a chronic coronary disease with hemodynamically significant left main coronary artery disease with more than 50% of stenosis on angiography. So here, definitely deferral of surgery and coronary revascularization is appropriate here. There is a class 1 recommendation for this. But otherwise, there is no routinely recommendation to doing coronary artery revascularization. Hypertrophic cardiomyopathy here, beta blockers continuation is very, very important. Avoiding hypovolemia and giving fluid is indicated, and avoiding tachycardia for prevention of adequate filling. So these are the recommendations by ACCHA guidelines. Valvular heart disease we still come across in India, and with aging population, the aortic stenosis is another class of patients we come across in the institute very commonly. So patient with severe mitral stenosis should be evaluated for the need of mitral valve intervention before elective surgery. But if patient is severe MS who cannot undergo mitral valve intervention before non-cardiac surgery, perioperative invasive hemodynamic monitoring is reasonable to guide management to reduce the risk of cardiovascular. Cannot undergo mitral valve interventions before non-cardiac surgery. Perioperative heart rate control is recommended by ACCHA guidelines. So similarly for aortic and mitral regurgitation, patient with suspected moderate or severe valvular regurgitation, preoperative echocardiography is recommended for elective surgery. But if patient is uh, indicated for valvular intervention based on clinical presentation of and severity of regurgitation, the need for vascular intervention should be considered before elective surgery. These are all in case of elective surgeries. Asymptomatic patients with moderate or severe MR or AR can be posted for surgery if there is reasonable, uh, it is reasonable hemodynamics are there, the LV function is stable. So again, recommendation for atrial fibrillation. Patients with rapid atrial fibrillation identified in the settings of non-cardiac surgery, it is reasonable to treat potential underlying triggers like electrolyte imbalance, sepsis, anemia, pain. And if it's a new onset atrial fibrillation in the setting of non-cardiac surgery, initiation of postoperative anticoagulant is recommended. And these patients post-discharge can be sent to cardiology OPD for follow-up in the regular basis. Aortic stenosis, I already spoke. So recommendations for stroke and transient ischemic attack. Patients with a history of stroke less than 3 months should be have a high incidence of cerebrovascular events in the perioperative period. So they should be ideally deferred for 3 months if possible, but if surgery is to be explained to the patients. Again, obstructive sleep apnea, if patient is scheduled for non-cardiac surgery and obstructive sleep apnea, screening using validated questionnaire is reasonable, and we may not summon further investigations, but if patient is using CPAP for obstructive sleep apnea, we should be continuing that measures for better outcome in the perioperative period. So, I spoke, statin should be continued. There is no doubt about it. Renin-angiotensin aldosterone system inhibitors in select patients of on chronic renin-angiotensin aldosterone system inhibitors. It should be omission of 24 hours before surgery may be beneficial in to limit the intraoperative hypotension. But patients on chronic RASI and heart failure patient, perioperative continuation is reasonable. So these are ACC-AHA guidelines 2024. Alpha-2 receptor agonists, we anesthetists are really fond of this, but there are no recommendations or no proven benefit of adding clonidine. So we may not start clonidine preoperative period. Calcium channel blocker routine initiation is not recommended, but if they are on, they should be continued. So again, I spoke about the time-sensitive surgeries. Here again, the optimal timing of elective or non-sensitive, time-sensitive coronary procedures. So like balloon angioplasty only is done, delay the non-cardiac surgery with a bare metallic stent for 14 days at least. If patient is on bare metallic stent, delay non-cardiac surgery for 30 days. If drug-eluted stent is placed and surgery is not emergency, we can delay it for 12 months, and alternative methods can be suggested till the time the patient crosses. But if it's an emergency surgery, we have to take a call with cardiology consultation. Here, the perioperative anticoagulant continuation with this newer oral anticoagulants, generally they should be stopped 3 days prior, and then they should be started as early as possible, depending on what kind of anticoagulants we are using. But if patient's creatinine clearance is less than 50 ml per minute, we have to stop them way prior, like at least 4 days before surgery, and then started at least day two of procedure, or earliest whenever it's possible to restart the anticoagulants, direct acting anticoagulants, especially. Beta blockers, I already spoke about. So, perioperative surveillance and management of myocardial injury and infarction. It may be reasonable to measure this troponin C at 24 and 48 hours after surgery in risk factors like patients with age more than 65, with known case of coronary artery disease. So, troponin increase risk, the increase in troponin level increases the mortality risk threefold. So it's a class 2 recommendation by ACCHA. But routine postoperative surveillance for low risk patients is not shown any benefit. So low risk patients, we are not supposed to summon all this, and neither cardiology advises us to do those things. And antithrombotic therapy with dabigatran has proven better to reduce the thromboembolic events. So if patient sustains non ST segment elevation MI, or non ST segment elevation MI in the perioperative period, so what are the recommendations? Patient who develops STEMI after NCS should be considered for guideline directed medical therapy, including consideration for invasive coronary intervention depending on the multidisciplinary team. But balancing the bleeding and the thrombotic risk has to be taken into consideration. Patients who develop non-ST segment elevation MI after non-cardiac surgery should receive a medical therapy as recommended for patients with spontaneous MI, but after considering the postoperative bleeding risk and hemodynamic status. So to conclude, preventing perioperative myocardial infarction is a crucial goal for anesthesiologists. Through comprehensive risk assessment, we can quantify the risk, optimize the patient, and by planning the individualized approach, meticulous intraoperative management can be done by anesthesiologists. And obviously, that vigilant postoperative care continues. Probably the incidence of perioperative myocardial infarction can be significantly reduced. And for better outcome, obviously, multidisciplinary approach is very, very important. And the way I spoke about ACCHA guidelines, these are evidence-based strategies we can utilize. And as a team, we can optimize the outcome of surgical patients. Thank you.
Thank you, Dr. Yogita. That was a very extensive coverage, very well summarized.
Yeah.
I just want to add just one thing, that pre-op optimization is the key for this thing, and also everybody should actually know some rescue echo. Means if you have that phased array probe can actually get attached to a USG machine, you need to have that, and everybody should learn it because it is very easy to do, and at least you can come to know if there is some unexplained hypotension, hypoxia, hemodynamic compromise, and accordingly we can very quickly treat the patient to improve outcomes.
Yes, we absolutely agree with you, because recently we have started getting 2D echo probes with UAG machines, and we are picking up the events at least better.
Yeah.
And then early involvement of cardiologist is definitely making a difference to outcome of patients.
Yeah, so at least you know whether you need to give fluids or you do need to restrict fluids, early use of vasopressors, and maintaining mean arterial pressures and good peripheral circulation is the key to better outcomes. Okay, right now I don't see any questions regarding this talk. So Manisha will move to the next talk and take questions later.
Yes, ma'am, we can do that.
Yeah, I just wanted to add something. Very nice lecture, Yogita ma'am, and explained very well. Uh, now, routinely we are doing these patients with IHT, and patients who are stented, they are coming for surgery. So intraoperatively, we should monitor when we attach the leads, we should monitor the affected site. Supposing if the patient has undergone RCA stenting, then we should monitor 2-3 AVF leads. If the patient has LAD stent or left main stent, then we should monitor those leads. So that is very important, and all of us have access to multi-para monitor where we can monitor multiple leads at one time. So that is very important. Secondly, I have seen two patients who developed intraoperatively. They developed thrombosis of the stent, and the ST started going up, and we ruled out all the other causes, but then we thought that it is patient is getting thrombosed, the stent is getting thrombosed. So we sent the tropi levels, and we informed the cardiac cath lab, and we kept everything ready, and we involved the cardiologist, and immediately the patient was shifted to the cath lab, and we could salvage that patient, and patient did very well. So anytime you feel any you see any abnormalities in STT, and you're not very sure, and one of cardiologist, you can send the uh, troponin levels, and keep the cath lab ready. So that really helps. Thank you.
Yeah, thank you, Parna. We'll move on to our next talk. So by Dr. Samrat Madnaik. He is a consultant cardiac anesthetist at Karad. He has a DM in cardiac anesthesia. Has a fellowship in transesophageal echo and also a fellowship in cardiac critical care, transthoracic echo, and ECMO. He has received Best Academic Achievement Award in 2018 as well as President's Appreciation Award SAMS in 2024. He has been part of the cardiac transplant team that performed the first successful heart transplant at KLE. He has also been faculty at many state and national levels. So I invite Dr. Samrat to give his talk on intraoperative arrhythmias.
Thank you, ma'am, for the wonderful introduction. I'm humbled. I hope my screen is visible to everyone and I'm audible.
Yes, it's visible.
Yeah. So very good evening to all the dignitaries, my respected seniors and colleagues. Myself, Dr. Samrat, and at the outset, I'd first like to thank ISA Thane branch and Society of Anesthesia Maharashtra State for providing us this prestigious platform and giving me an opportunity to present at this prestigious platform. So, without wasting any further time, I would start with my topic, and I have slightly modified the topic, and I've written it as perioperative arrhythmias, diagnosis and management, just to be more focused. Disclosures: anything wise in the presentation, you should credit to the many experts who have preceded me. Anything foolish, please assume it as my error. These would be the objectives of my talk. First, I'd go through history and introduction. I'll talk a bit about perioperative tachyarrhythmias and bradyarrhythmias. I would also discuss in short about the recent advances, and then there is a take-home message. I'd like to make this lecture as practical as possible. Now, if you look at the history, in the olden times, maybe they used to anesthetize the patients like this. Well, I'm glad I'm not in that era, or else this talk wouldn't be happening. Now, the first documentation of intraoperative arrhythmias was in the patient Katharina Serafin, and the surgeon was Hugo Wilhelm von Zimsen. And this was an enchondroma of chest wall removal, and it was done way back in 1892. So, the first documentation of this intraoperative arrhythmia was in the year 1892. Claude Beck did the first successful defibrillation intraoperatively, and that was in the year 1947. Now look at this image. What do you see here? A monster trying to scare the person. But is it the truth? Well, absolutely not. The problem is actually very small, but we have created monsters out of it. So whether these arrhythmias are actually a monster or whether they are very simple things which we have created monster out of them. Let us demystify in this lecture. If you look at the ACC AHA guidelines, especially the 2014 guidelines, what does the 2014 guidelines say? So they have included significant arrhythmias as one of the major clinical predictors of morbidity and mortality. So significant arrhythmias have been included as major clinical predictors in the patient outcome in the perioperative period. Now, what causes these arrhythmias? So basically, there is a substrate factor, what you see over here, and then there is a trigger factor. So what are the substrate factors? Age more than 60 years, male gender, history of AF, hypertension, congestive heart failure, inflammation, genetic predisposition. These are all the substrate factors. Anesthetic agents and drugs, ABG abnormalities, temperature changes, laryngoscopic responses, reflexes, autonomic disturbances, pre-existing cardiac diseases, surgical manipulations, increased catecholamine levels in the perioperative period, and neuroendocrine pathology are the trigger factors. So whenever we have a substrate and whenever we have a trigger, then there is a high possibility that arrhythmias can occur. Now, the golden question, is arrhythmia dangerous? Yes. And when is it dangerous? When it produces hemodynamic changes. So whenever we come across arrhythmias, we need to ask few questions. So these are the set of questions that we need to ask. So the first question that we should ask is, what is the heart rate? Second, is the rhythm regular? Third, is there one P wave for each QRS complex? Fourth, is the QRS complex normal? Fifth, is the rhythm dangerous? And sixth, does the rhythm require treatment? Now look at this image. What do you see here? These are four people and they are rowing the boat in harmony. As a result of which this boat or this thing is sailing very smoothly. Whereas look in this image, what is happening here? So there is no coordination between the different people over here. As a result of which the motion of the boat is not in synchrony or the speed is very slow. So same occurs with the heart. And whenever there are arrhythmias, definitely there will be suboptimal function. So coming to normal sinus rhythm. So we all know about this. I don't need to explain it in detail. In normal sinus rhythm, we have a upright P wave and the morphology remains always constant at all times. The PP and the RR intervals are always regular and equal. And the atrial and the ventricular rates are identical and usually between the range of 60 to 100. And there is no ectopic activity. So this is how a normal sinus rhythm looks like. This is how it looks like on the monitor. So you can see a P wave followed by a QRS complex and there are no ectopics. This is how it looks intraoperatively. So basically this is the right atrium, what I'm pointing right now. This is the right ventricle, this is the aorta, and this side is the left ventricle. So you can see there is a synchronous contraction or synchrony occurring between the atria and the ventricle. Coming to sinus tachycardia. So what exactly is sinus tachycardia? So basically, whenever the rate is more than 100 per minute, we label it as sinus tachycardia. This is how it looks on the monitor. The rhythm is usually regular and the P to QRS ratio is 1:1. And the QRS complex is usually normal. So this is how it looks on the monitor. So you have a P wave, you have a QRS complex, and the ratio is 1:1, and the rate is more than 100. So in real time, this is how it will look like. You have a rate which is high, and then there is a P wave followed by a QRS complex, and there are no ectopic activities. Intraoperatively, it looks something like this. So here there is synchrony between atria and the ventricle, but just the rate is high. So this is sinus tachycardia. So sinus tachycardia can cause less time for diastolic filling and increased myocardial O2 consumption, as a result of which it can be detrimental and patient can land up into trouble. So the underlying cause is usually pain, hypoxia, hypovolemia, or anxiety. And the treatment usually involves treating these causes. So if the patient is in inadequate depth of anesthetic plane, then you have to increase the depth. If there is hypoxia, treat hypoxia. If there is hypovolemia, treat hypovolemia. And if the patient is awake and anxious, then you can give some sedation. Beta blockers and calcium channel blockers can also be used in these scenarios. Coming to supraventricular tachycardias. So this is how supraventricular tachycardia looks on a monitor. So the characteristics are the rate is usually between 150 to 250. The rhythm is regular. Now, the P wave is often hidden in the QRS complex. So if you see here, if you observe closely, the P, you won't be able to appreciate the P wave. So because it is hidden in the QRS complex, and the QRS complex is usually normal. This is how it looks on the monitor. So this is a patient with supraventricular tachycardia, and the atria basically are beating very fast, and you are not able to see the P wave. So treatment of supraventricular tachycardia is carotid sinus massage, giving adenosine in incremental doses, starting with 6 mg and going up to doses like 12 mg intravenously. Beta blockers and calcium channel blockers can also be used. Digoxin in the dose of 0.05 to 0.1 mg intravenous. Sometimes in some situations, especially in cardiac surgeries, we can use rapid override pacing. So basically you can set the pacemaker rate to a very high range, which usually causes the or captures the ectopic focus, and it terminates the supraventricular tachycardia. If this supraventricular tachycardia is unstable, or if the patient has unstable hemodynamics, usually we proceed straight away to synchronized cardioversion. But if the patient is stable, then hemodynamically stable, first we proceed with pharmacological treatment. And if patient is not responding to this therapy, then we go forward with synchronized cardioversion. So what is happening over here? So always, whenever you are looking at arrhythmias, you should always remember what to look on the monitor. So if you see closely in this picture, the person is trying to ask for a disaster. So never land up into such a situation whenever you are treating patients intraoperatively. Coming to atrial flutter, the characteristics of atrial flutter are atrial rate is usually high. It is between 250 to 300. The ventricular rate is between 150. Rhythm is atrial rhythm is regular, ventricular is regular or irregular with variable degree of AV block. And the P waves, are usually called the flutter waves, and they have usually the sawtooth appearance. So sawtooth appearance is a characteristic for atrial flutter. The QRS complex is normal, and the T waves are usually lost in the flutter waves. So again, the treatment for atrial flutter is treatment of the underlying cause, like correction of the abnormalities, correction of hypoxia, or any other causes. Then to slow the ventricular rate, we can use either digoxin, beta blockers, or calcium channel blockers. We can slow the fixing rate of atrial focus by use of drugs like amiodarone or quinidine. Most commonly used is amiodarone. Again, rapid override pacing can be used in these scenarios. And if the patient is unstable and not responding to the pharmacological therapy, then synchronized cardioversion can be used. Coming to atrial fibrillation, this is how a patient of atrial fibrillation looks like. So usually the rate again is very high. Atrial rate is between 250 to 400. Ventricular rate is usually between 60 to 170 or 200. The rhythm is irregularly irregular. So irregularly irregular is the characteristic of atrial fibrillation. The P wave is absent, the QRS is normal, and the RR interval is irregularly irregular. So this is how it will look on the monitor. This is how an atrial fibrillation looks in the real time. So this is the right atrium, what you are seeing over here. This is the right ventricle. So you are seeing the rate of right atrium is very high and it is fibrillating. And whereas compared to the atrium, the ventricular rate is slightly slower, and there is no synchrony between the atria and the ventricle. So this is basically an irregularly irregular rhythm. This is how it looks on the monitor. There is absence of P waves, and in this particular patient, the hemodynamics are slightly on the lower side. So basically, for this patient, when you face such a situation with high rate and the patient landing up into with unstable hemodynamics, the treatment usually is synchronized cardioversion. So what happens with atrial fibrillation? So if you compare this person and we consider him as a patient with atrial fibrillation, while this patient on the right side is with sinus rhythm, what you see here, always, in spite of everything, there is suboptimal performance of the heart in patients with atrial fibrillation. And that is because almost around 25 to 30% of the diastolic filling occurs during the atrial contraction. So as a result of which, if the patient is in atrial fibrillation, the complete diastolic filling of the right ventricle won't occur, and as a result of which the cardiac output will be hampered. Now, inadequate atrial contractions, they lead to inadequate ventricular filling. And always remember, if the patient is hemodynamically unstable, we should use cardioversion. Rate control drugs like digoxin, beta blockers, calcium channel blockers, or amiodarone can be used. And anticoagulation before and after cardioversion is always advocated. Coming to ventricular ectopics. So this is in the first image here, you can see an ventricular ectopic. This is a patient with bigeminy. And in the second image, again, you can see here the ventricular ectopics are occurring. So the characteristics of ventricular ectopics are the rate depends on underlying sinus rate and frequency of VPCs. The rhythm is usually irregular. No P waves are seen before the QRS complex over here, and the QRS complex is widened, that is, it is more than 0.12 seconds. And usually a compensatory pause follows after the ventricular ectopic. So here you can see a compensatory pause is there after the ventricular ectopic. So this is one patient who has ventricular ectopic, just one or two ventricular ectopics occurring, and the hemodynamics are quite stable. So basically, you don't need to treat this patient, but you need to keep a close watch on this patient. While in the second patient over here, you can see there are multiple ventricular ectopics which are opening, and this is a dangerous rhythm. You can see here. So almost 3-4 ectopics have occurred over here, and the hemodynamics are towards the lower side. So definitely this second patient will require aggressive treatment and monitoring. So this ventricular ectopics, always remember, they can predispose to ventricular tachycardia or ventricular fibrillation. Usually no treatment is required if the patient is asymptomatic. But if the patient is symptomatic, lignocaine in the dose of 1.5 to 2 mg per kg IV, prosinamide in the dose of 22 to 30 mg, or amiodarone in bolus doses of 150 to 300 mg can be given. Now look at this image, what is happening over here. President Bush is trying to look at something, but what is actually happening? So the caps of the binoculars are closed. So always remember, whenever you are looking at arrhythmias on the monitor, don't be or land up in a situation like this, or always keep your vision open. Coming to ventricular tachycardia, this is how a ventricular tachycardia looks like on the monitor. This is an animation for ventricular tachycardia. The characteristics for ventricular tachycardia is the rate is usually between 100 to 200 per minute. The rhythm is regular or irregular. The P to QRS ratio is, there is no fixed relationship. And the QRS complex is not normally looking, and the QRS duration is usually more than 0.12 seconds. And ST and T waves in opposite polarity can occur as compared to the QRS complex. So whenever you see a rhythm like this on the monitor, always remember this is nothing but ventricular tachycardia. Now, ventricular tachycardia can be of two types, with pulse present or pulse absent. When the patient has a pulse present, then usually we call it as pulsatile VT, and you have to always evaluate the vital signs of the patient. And treatment usually involves the pharmacological treatment in the form of either xylocaine or amiodarone. And if unresponsive to medical therapy, you need to cardiovert this patient. So you need to do this part of algorithm for the treatment of the patient in patients who have pulsatile VT. Most of the times, patients with ventricular tachycardia will not have pulse, and that is called as pulseless VT. And always remember, it is life-threatening, and without any delay, begin CPR and defibrillate the patient immediately. In cases of recurrent VT, remember, oral antiarrhythmic drugs can be used, or automated implantable cardioverter defibrillator devices can be used, or if advanced facilities are available, catheter ablations can be done. This is how a ventricular fibrillation looks like. All of us almost once or in our practice must have come across such a rhythm, which is absolutely a nightmare for everyone. The characteristics are the rate is rapid and grossly disorganized. The rhythm is irregular. The QRS complex is not normally looking. Early in the course of ventricular fibrillation, the fibrillatory waves are exaggerated. So basically, these are coarse ventricular fibrillations. But after several minutes, then they become smaller and smaller, and then it is called as fine ventricular fibrillation. So always remember, in ventricular fibrillation, there is no effective cardiac output, and resuscitation in the form of CPR and defibrillation must be started immediately. So here you should not waste any time after you diagnose this rhythm, and immediately CPR along with defibrillation must be initiated. So this is how ventricular fibrillation looks like in a real time. So here if you see the ventricle, this is the right ventricle, this part is the left ventricle, and it is fibrillating. And this is an intraoperative video, and we are the defibrillation has been attempted with the help of internal defibrillator. So once the shock has been delivered, now the both the atria and the ventricles are contracting in synchrony. So the treatment is CPR, early defibrillation, establish airway and oxygenate, establish venous access, and drugs like amiodarone, magnesium, xylocaine, adrenaline should be used in these scenarios. Now, a special mention about a particular rhythm, that is torsadis de pointis. So, if you come across such a rhythm, then remember this is nothing but torsadis de pointis, and it looks like a party streamer. So, in the earlier times, we had party streamers which we used to apply during birthdays and functions. So, here the main problem with this rhythm is it will ultimately lead to ventricular fibrillation, and patient will land up into patient will land up into no cardiac output. So treatment of choice is magnesium sulfate and electrical cardioversion. So whenever you come across such a rhythm, instead of allowing it to progress to further steps, always remember to administer the patient with magnesium sulfate and do electrical cardioversion. Now, in cath labs, many a times for such tachyarrhythmias, this anti-tachycardia pacing is done. And for fast ventricular rates, there is a device. There are AICDs, and this usually, whenever the fast rates are detected, it is detected by the machine, and then shocks are delivered. As a result of which, again, the rate is controlled and the rhythm is established. Coming to bradyarrhythmias, this is how bradyarrhythmia, sinus bradycardia looks like on the monitor. I don't need to explain it in detail. So the characteristics are the rate is usually less than 60, the rhythm is regular, the P to QRS complex is 1:1, and the QRS is normal. So this is how it looks like in the real time. So always remember, in presence of a slow heart rate, patients with diseased heart may be unable to maintain adequate cardiac output. So as a result of which, if the patient has landed up with sinus bradycardia intraoperatively, sometimes patients who have compromised LV function, these patients won't be able to maintain the cardiac output. So in this subset of patients, especially patients with poor ejection fractions, you should always treat sinus bradycardia. So the treatment is treat the underlying cause like withdrawal of drugs that cause bradycardia or vagal stimulation. Drug therapy with signs of hypoperfusion includes adrenaline, dopamine, or dobutamine. Drug therapy without signs of hypoperfusion include atropine or isoprenaline. And when drug therapy is ineffective, always remember you have the option of temporary or permanent pacemaker. This is how a nodal rhythm looks like on the monitor. So the characteristics are the rate is usually between 40 to 60. The rhythm is regular. The P to QRS ratio, the P waves are absent and QRS is normal, and RR interval is always regular. So what you see here is the P waves are absent, the QRS is present, and the rate is towards the lower side. So this is how it looks like in a real time. So basically, this was a patient posted for cardiac surgery, and while coming off bypass, we had nodal rhythm. You can see here there is no atrial contraction and the ventricular rate is there. So usually, no treatment is required in these patients. Withhold any drugs that may depress the SA node like digoxin. If associated with signs of hypoperfusion, always remember to give injection atropine, adrenaline, or isoprenaline. And if hemodynamic instability persists, then the temporary or permanent pacemaker can be initiated. Coming to first degree heart block. So basically, first degree heart block represents consistently prolonged conduction between the atria and the ventricles. And it is characterized by prolongation of the PR intervals. So basically, in first degree heart block, what do we have? We have a PR interval which is more than 0.2 seconds. So this is how a normal sinus rhythm looks like, while in AV blocks, it looks like this. So basically, there is some conduction disturbance at the AV node, as a result of which the electrical conduction is not progressed further. So in first degree heart block, remember the PR interval is more than 0.2 seconds. This is how an AV block looks like. And this is how an patient with LBBB looks like, or the conduction occurs in LBBB. Coming to second degree heart block. So second degree heart block is again classified into Mobitz type 1 and Mobitz type 2. So here what you are seeing, this is Mobitz type 1 kind of heart block. So Mobitz type 1 reflects intermittent conduction between the atria and the ventricles, and it is characterized by progressive lengthening of the PR interval until a QRS complex is dropped. So here in Mobitz type 1, you will have progressive prolongation of the PR interval. So this is P wave, this is QRS complex. This you can see here, the PR interval is getting progressively increased, and suddenly there is a drop of QRS complex. Coming to second degree heart block, Mobitz type 2. So in type 2 heart block, it reflects intermittent and sudden loss of conduction between the atria and ventricles, and it is characterized by intermittent and sudden appearance of drop beats. And the characteristic is there is no progressive lengthening of PR interval. So in Mobitz type 2, if you see here, there is no progressive prolongation of the PR interval, but suddenly there is loss of the QRS complex. So always remember which is more dangerous rhythm between Mobitz type 1 and 2. It is always Mobitz type 2, because Mobitz type 2 blocks can progress to type 3 heart blocks, or they can cause cardiac arrest. So never ever ignore this rhythm whenever you see this on the monitor. Look at this image. What is happening here? Children are trying to read the books, but look at them. They are sitting on the wall. So how is it possible? So if you just change your perspective, you will come to know the real answer. So the truth is this. So always remember, when you are dealing with arrhythmias, you need to keep your mind open, and always you need to have newer perspectives. Coming to third degree heart blocks. So third degree heart block represents a complete absence of conduction between the atria and ventricles, in which there is no relation between the P waves and the QRS complex. So basically the P wave and the QRS complexes are not related at all, and they keep on beating on their own. So this is how a third degree heart block looks like on the monitor, and never ever try to ignore this rhythm whenever you come across such a rhythm, because it can lead to cardiac arrest. So then what is the treatment for this? So the treatment is withhold all the causative agents. If hemodynamics are unstable, then atropine, isoprenaline can be used. And always remember, temporary pacing can be used in either emergency situations, and permanent pacing can be used if once the patient is stabilized. So you can use temporary or permanent pacemakers. The permanent pacing is usually done in the cath lab. So what we usually do in the intraoperative period is temporary pacing. So here, this is again a cardiac patient in which we have inserted a temporary pacemaker. Basically, this is an epicardial pacing wire which has been placed. Coming to this rhythm, asystole. So in asystole, there is nothing much to tell. There is complete absence of electrical activity on the heart. It may follow after cardiac arrest or VF or pulseless electrical activity. There is no rate. The rhythm is usually a straight line, and there is no QRS complex. But always remember, before you diagnose this, make sure that your ECG connections, the patient end of the monitor, all the cables are properly connected to the monitor, and have a look at the patient before diagnosing this rhythm. So this is how it looks like on a monitor. So here initially we have a few beats, then there is a complete flat line with absence of any hemodynamics. So don't worry, this patient was okay, because this is just for an example purpose what I'm showing. This was a patient who underwent cardiac surgery, and we have delivered cardioplegia over here, as a result of which there is asystole, and the patient was on cardiopulmonary bypass. So always remember, the etiology can be failure of normal intrinsic cardiac pacemaker like drugs or MI. The treatment is CPR, early defibrillation. Drugs like ephedrine or vasopressin can be used. And always remember, initiate external pacing as soon as possible. So this is how usually they insert a permanent pacemaker in the cath lab. So usually the access is through the subclavian vein, and after a puncture, the lids are placed. The lids go via the vein, go through the SVC. There is a sheath through which the leads are passed, and then they come to lie in the right ventricle, after which the lids are tightened with the help of screwing motion, and then they are connected to a battery or an external pacemaker, and then the patient is paced. So now coming to some examples, or rather, I'll say this is just an example which I have adapted from the internet. It is not my own example what I'm trying to present, but this has been adapted from the internet. So let us look, or let us call this as the song of life of the arrhythmias. So here we consider P wave as the wife and the QRS as the husband. So in normal sinus rhythm, always remember, the husband, that is QRS, comes always after the wife, that is P, and it is always regular and they are happy. So this is normal sinus rhythm. The husband comes always after the wife, and the timing of the husband and the timing of the wife to come home is usually regular, and they're always happy. So this is normal sinus rhythm. In first degree heart block, the husband always comes after the wife, and but he comes slightly late at the same time every night. So basically there is some problem, not a huge problem, but there is some problem. Now, in second degree heart block type 1, that is Mobitz type 1, the husband QRS comes home later after the wife, and the duration of its stay progressively increases until one night he doesn't come home. And again, the same routine continues. So, in Mobitz type 1, if you remember, there is progressive prolongation of the PR interval. So, here the QRS complex, that is, the husband is coming home later after the wife, and the duration is constantly prolonging every day until one day is not coming home. And this is an example for type 1 Mobitz kind of block. In type 2 block, sometimes the husband, that is the QRS, comes home, sometimes he doesn't, and the wife is waiting at home. But when he comes home, it is always at the same time, and this is more serious and always requires counseling. So that is basically pacing. In third degree heart block, the wife is no longer waiting at home. She and her husband are now separate, have separate schedules, and they have no relationship, and they are not no longer talking. Each spouse has an individual regular schedule, and this is absolutely serious and requires counseling, and that is pacing. In atrial and ventricular ectopics, remember the wife P and her husband QRS always compensate for each other. In SVT, the wife P is abnormal and her husband QRS compensates for her. In VFO or VT, the wife P is normal and her husband QRS is not there, and the rhythm of life goes off. So coming to some recent advances. So basically now, since this is an era of echocardiography along with advanced echocardiography like strain imaging, so we have different strain parameters, and now currently research is going on global longitudinal strain, whether the strain patterns can predict whether the patient can have intraoperative or perioperative arrhythmia. So this is a topic for research which is ongoing currently. Similarly, echocardiographic assessment of LS strains are being done now to know whether the patient will land up into perioperative arrhythmias. So this is again, a few studies are upcoming. Let us see what it has to offer in the coming time. A few drugs have come up like dronidarone, and there are a few new therapies which have come, right? That is a Farapulse which has come, which can ablate these arrhythmias, and these therapies are now available. Always remember, the last option in any kind of arrhythmia, especially in an advanced setup, is ECMO. So whenever the patient is not responding to anything, and if you are having an advanced setup, remember that you have an option of ECMO, that is the veno-arterial ECMO, wherein you can temporarily support the patient for a while till the cardiac rhythm gets stabilized. But of course, again, this comes with its own set of complications, and this is a costly affair. Now, always remember, whenever you deal with arrhythmias intraoperatively, remember to keep your head cool, like we guys did the previous year and won the World Cup. So always remember, you have to keep your head cool. So the take-home message is, not all arrhythmias are fatal. Do not panic. Concentrate on the diagnosis. Correlate with other signs and symptoms of the patient. Optimize all correctable causes, that is the 5Hs and the 5Ts, and treat the patient and not the monitor. These are a few of my references. Thank you.
Excellent talk, Dr. Samrat. Very entertaining also. You made it very interesting.
Thank you, ma'am.
I wanted to ask you just one question, since you are also into heart transplant. So what about transplanted hearts when they come for non-cardiac surgery? So how do you
Right.
treat the bradycardia?
So basically, the transplanted hearts, when they come for non-cardiac surgery, you have to be very cautious because your sympathetic, parasympathetic innervations are all gone. So you have to deal bradycardias in these patients very carefully. And these patients, many a times, they have their own intrinsic rate. So do not try to overcorrect them. But usually they don't respond to atropine or the standard pharmacological therapy. So whenever you land up in such situations, remember that you always have an option of pacemakers which is available, especially transcutaneous pacing which is available. So it can be done in these situations. It can come handy.
Thank you. Any other questions? I think it was an excellent talk. Any other questions to audiences? Manisha?
Audience can ask questions to any of the three speakers now if they have anything to say. There was one comment from Dr. Shailesh Murgaonkar sir. Sir, are you there? It was directed to Dr. Pallavi's talk actually. So he was talking about the rescue block. If your first block is not acting, then he would go in for rescue block after 15 minutes. And then he mentioned that instead of going ahead with various types of pseudo analgesia, he would prefer to do a fiber optic intubation and give a proper general anesthesia.
Yes,
So
ma'am.
Pallavi,
Yeah,
yeah.
I agree with that. If the patient is like we are anticipating a very difficult airway and our block has been patchy, around 15-20 minutes has been over, and even after the repeat block it's not acting, then there is no point in going ahead with the repetitive pseudo analgesia doses. Instead of that, we can abandon the procedure or take him for the awake fiber optic, or go ahead at the time of fiber optic for the difficult airway. And as madam has said, that preoperatively only we have to take consent from a patient that these are the problems we can land up, and the GA can be given, or the GA also, the intubation also can be difficult. So the point is well taken by sir.
One more question for Dr. Pallavi was there by Dr. Sanhita Kulkarni, that if the block is patchy, after how much time reblock is given and how much dose of local anesthetic will you repeat?
Uh, that's like in a clinical practice also, and we generally, as we saw, that 15 to 20 minutes is the time required to, when we give a first block, ideally we should wait 15 to 20 minutes. If after that, if there is no action at all, there is like absolutely no action, then we can always repeat. And the repeat dose, in a literature, I didn't come across any guidelines with how much should be the dose repeated, but we should always know the total toxic dose. As like for bupivacaine, we got the reference, but lignocaine toxic dose, as we remember, if we are adding adrenaline, then it goes to higher dose. Like we can give a more lignocaine, about 5 to 7 milligram per kg we can go. But I didn't come across the particular, dose to be repeated of a lignocaine. For bupivacaine, we saw that around we can repeat the dose after 3 hours, and the maximum was 400 milligram for 24 hours.
Yeah.
So already 15-20 minutes, and for that they say that we should have a separate room for block, and we should be friendly with the surgeons, and we should explain that take a patient half an hour before, have a good time for our block to act, and give more and more blocks. As we give more and more blocks, I think we'll be more uh confident enough that okay, now the after 10 minutes only we'll come to know that now this block has been acted. Okay, but ideally they say that 15 to 20 minutes for first block.
Okay, any other questions from the audience?
Yeah, and one more, this thing was mentioned about supraclavicular approach. I agree with that also. Instead of repeating axillary, we could have got with the supraclavicular approach. Only axillary block in this case. Instead of that, we can initially only given a supraclav plus axillary, some small volume of drug in a supraclavicular approach and plus axillary. That could have been also done. Or first axillary has been failed, so next time we can give injected drug at the supraclavicular approach. So that was mentioned in the chat. So I agree with
Yeah.
that.
But when you give a reblock, that time the anatomy, I think, will be distorted after deposition of the first drug. So you will not be able to see the nerve roots very clearly.
Yeah,
So
maybe the
that
repeat
can be
drugs. Yeah,
difficult, reblock, if you're
yeah,
giving USG guidance.
yeah. Whenever
Because
you are
so
giving
many
the first block only, that time only because of the drugs and the that
dissection.
hydrolocation,
Hmm.
the anatomy can be, distorted. So we have to be
Yes,
careful.
yes.
There is a
These are
question.
the tricky. Sorry.
There's a question for Dr. Yogita. How significant is complete or incomplete RBBB in the pre-op ECG? Should we worry?
I guess that is more for Dr. Samrat, if you can answer.
Yeah, sure.
RBBB as such, uh,
To worry so much.
Yeah, so basically, whenever you are dealing with RBBB, always remember there is some pathology which is going on. So, how do you diagnose basically an RBBB? So, basically, RBBB is with a QRS duration of more than 0.12 seconds, and you have an RSR dash pattern in V1 to V3. So in adults, it is usually significant, but in children, usually when the QRS complex is less than 0.12, and if there is an RSR dash pattern, then we call it as incomplete RBBB, and it is usually not pathological. It is quite common, so you don't need to treat this. But in adults, if you come across an RSR dash pattern, always remember in the preoperative evaluation, that should not be ignored, and you at least need to do an echocardiography, and you need to know what exactly could be the cause of this. So there can be different causes for an RBBB. It can be due to ischemia, it can be due to cardiomyopathies, or many other reasons like cor pulmonale or maybe pulmonary embolism. So all these situations can lead to RBBB. So it basically depends on diagnosing what has actually caused this RBBB, especially when this is an elective case. And in emergency case, you have no option. You need to proceed further. And always remember, RBBB always again should be differentiated from a syndrome called as Brugada syndrome. So basically, in Brugada syndrome, again you have this RSR dash patterns or ST elevations between V1 to V3, and this syndrome is usually very detrimental, or it has to be tackled very properly in the perioperative period. So that is the thing. So basically, for complete RBBB in adults, remember you need to diagnose what has actually caused it, and in cases of incomplete, in especially in children's, just you can proceed ahead.
Okay, one question for Dr. Samrat. How much adrenaline to be given if no response to bradycardia to atropine, and the dose of magnesium sulfate in torsades?
Okay. So basically, if you look at the AHA guidelines, especially for advanced cardiac life support, now I'd like to quote here the guidelines from ACLS, that is AHA guidelines. So initially they used to say give an atropine dose of 0.6 mg, but that has completely been replaced now. Now the newer guidelines say you need to give a dose of 1 mg, which is a standard dose, and this dose needs to be repeated thrice. So if the patient is not responding to this dose, then you need to proceed to other agents like either dopamine or adrenaline. So the dose of adrenaline, if you ask me, for these patients, usually it ranges between somewhere around 0.05 micrograms per kg per minute to zero point 0.1 micrograms per kg per minute. And if you are using an infusion of dopamine, then usually 5 to 20 micrograms per kg per minute is the dose. Regarding MgSO4, especially in the use of Torsades day pointis, we usually give a loading dose of around 2 to 4 mg. That depends on the clinical scenario. And this dose has to be given very slowly. Always remember, do not give it like bolus of an induction agent or something like that. It has to be given over a period of 5 minutes to 10 minutes and diluted and in a very titrated way. And once this bolus dose has been given, then you can continue with an infusion of around 0.5 to 1 grams per hour. That is the infusion that can be continued.
Yeah. Thank you, Dr. Samrat. Then a question for Dr. Pallavi. Any clinical practice guidelines regarding appropriate site of injection of local anesthetic within the facial sleeve, around the nerves, or outside it?
The separate guidelines for plexus sheath block have not been there as I was going through the literature. Many sites for the regional anesthesia like Nizora, and there is this Asra, this site is there, but it's basically when they say that we have to prevent the nerve injury, peripheral nerve injury, that we should not directly inject into the intrafascicular compartment of the nerve. And that's why in the clinical practice also, when we go inside, we get the pop. that time we wait. So that means we have pierced the fascia. So as such, there are no published guidelines of separate plexus sheath block. Mainly only a singular cervical plexus, superficial cervical plexus block is there. But separate guidelines for all the plexus blocks, I didn't come across. But clinical practice also we do like that only. And even with we are teaching the students also. Did you get the pop? Did you get the pop? And you go across the nerve, instead of directly. Sometimes in USG also we cannot see the nerve, the needle,
Tip.
and whether it is actually inside in the nerve inside one. Sometimes we are nowadays PNS. That's why PNS and USG always will be better
Yes.
when the so
Especially
on
when
the
you're learning, you
learning.
should better to use both, so
Yeah.
you are sure that you're not you're not intraneural.
Yeah, it is always better. Like if the needle is not seen properly with some kind of movement of the patient, and at that time PNS is showing the response on point 3, that means you come out. So when you get that pop kind of thing, you are inside the plexus, and it need not be, the needle should be poking the needle. That's the thing. So for the answer, I didn't come across a separate guidelines for plexus sheath blocks, but normal sites for the regional blocks we can always refer to.
Hello, can you just talk for 2 minutes?
Yes, please,
Uh,
Dr.
I've
Nidhakar.
done quite a few cases of torsades pointers. They do a thoracic sympathectomy
Mm.
with VATS. And for those cases, normally we start with Cardaron infusion pumps. The main contraindication for that is long QT interval. If there's a long QT interval, do not start Cardaron.
Mm.
Yeah, that is the main point which I wanted to discuss. Yeah, so we give one lung anesthesia and collapse the left lung, and they do VATS and do a thoracic sympathectomy for torsades because they go into VTAC storm, and because of multiple VTACs, the battery drains out for the pacemaker. Yeah.
Absolutely. Yeah.
But excellent presentation. Your PowerPoint presentation was very good.
Thank you. Thank you, sir.
Yeah, great presentation, Dr.
Yeah.
Samrat.
Thank you.
Thank you, Dr. Shailesh.
Yeah. Thank you. Excellent.
It's an open house. If anybody wants to ask any
Anybody
questions,
wants
you
to
can
ask any
unmute.
questions, please go ahead. All the three talks were really good.
Excellent talks.
Excellent talks, excellent webinar.
Yes, very nice presentations, all.
Lilima can
For the benefit of the all the viewers, especially the people who are into non-cardiac part, I would like to just tell one thing that you need to get yourselves acquainted with the echocardiography now, especially when you are dealing with perioperative ischemias or myocardial infarctions, because this is one modality which is going to change the outcome of your patient whenever you come across such situations. So I had a few clinical scenarios in my practice. Just recently, 1 year back, I had a patient posted for RFA ablation, and this was actually a some very simple procedure, elective procedure. The patient was ASA 2, 45 years old male patient, and usually our surgeon used to require general anesthesia for this patient. So I had induced him, and after induction, he had some unstable hemodynamics, and there were not gross ST elevations, but I felt subtle ST changes. So fortunately, I had a T probe with me. I inserted, the patient was under GA, and I found that there was regional wall motion abnormality in the infralateral septum, and I confirmed it with the help of strain imaging on echocardiography. And immediately, what we did was I had to give him some heparin bolus, and I started him on some NTG. Asked my surgeon to wrap up fast. The surgery went uneventful, and in the postoperative period, we subjected him for angiography. And absolutely, there was a lesion in the proximal RCA, which was stented afterwards. So, basically, what I want to tell you is all of us should now, it is the time that we get acquainted with this modality of echocardiography, because this is what will help us to distinguish what is exactly going wrong with the patient, whether it is decreased contractility, whether it is hypovolemia, whether it is decreased SVR, or whatever, for whatever reason.
Yeah, I absolutely agree. And if not TEE, if TE may not be available to everybody, but at least a transthoracic, I
Transthoracic.
mean,
Yeah.
focus we have to know, because that, like Dr. Samrat said, gives immediate diagnosis and we can give the right treatment, which is very important and for better outcome. And Dr. Vijay also conducts a very nice program in Fortis. Anyone can just go, and it's just a 1-day program. You can just go and learn that rescue echo.
Any more questions? Or we can ask Nilima to give the vote of thanks. Parna, anything you want to say? Done. Okay.
It was very nice. I was very happy.
Yeah.
Excellent.
And I
Thank you,
hope,
all the speakers.
yeah, we have to, and I hope Pallavi is happy because this, we had promised her that the first webinar that we have after the CME will be for you. And Pallavi, I
Thank you.
think you got an even greater audience today than it would have been there at the CME.
Oh,
Yeah.
thank you, madam.
Thank
I'm
you
so
so much,
thankful to
Pallavi, for being so gracious about it that day. Thanks a lot.
And your presentation was very
No,
well.
afterwards I thought I was little childish, but I really
No,
felt
no,
bad
no.
because,
No,
you
not at all, not at all, not at all.
Presentation, good slides and everything. We read the slides very well.
Thank
For the,
you.
for the CME, it was, last time.
It was short time. Yeah. I think whatever happens, happens for the best, I think.
Okay, Nilima.
Yes.
Thanks.
Should we wind up now?
Yes.
Yes, yes.
Yeah. So thank you, Thane ISA, for such wonderful webinar. Thank you, SAM's office bearers, for all the support. Thank you, Dr. Supriya, moderator for today, for excellently moderating the session. All the three topics were extensive and too good. So I thank all the three speakers, Dr. Pallavi, Dr. Yogita, and Dr. Samrat. I thank you all the delegates. I think we had around 100 delegates today logged in, for the overwhelming response. And thank you, Jeneka Technology and Mr. Ganesh, for this seamless transmission. Thank you so much. And in future, we will be coming out with wonderful webinars. So please keep checking our group, WhatsApp group for that. Thank you.
Thank you.
Thank you, everybody.
Thank you.
Thank you.
Thank you all.
Thank you and good night.
Good night.
And all Thaneites, we are meeting again on 1st of March
Yes.
for our narcotic beat 7.
For our cultural activity, which we call Narcotic Beats, this will be the 7th session. And Pallavi has a major role to play there also. So we are very happy to have Pallavi for Narcotic Beats as well.
Yeah.
Also, I want to just make an
It's
announcement
my
in the month
pleasure
of
to be associated with
yes.
Thane ISA, ma'am. Yeah,
In April, we are actually having a USG guided regional CME. It will be a 1-day CME which is organized by the Department of Anesthesia, RGMC. So the flyers will come out soon and everybody is invited for that also.
So see
thank
you all on 1st of March after the
And
video
this recording will be there. So it's such a wonderful webinar.
It's
Yes,
there on
yes.
YouTube. Already the YouTube
Yes.
also many people have joined
Yes.
in and
Yes.
it will be there for posterity.
Yes.
Okay.
Thank you everybody.
Okay.
Good
Thank
night.
you. Good
Thank you,
night.
Parna.
Thank you. Thank
Nilima.
you
Thank
all.
you, Yogita.
Thank you
Thank you,
all.
Good
Dr.
night, all
Samrat.
of you.
Thank
Thanks,
you.
Pallavi.
Thank you.
Good. Yeah, good night.
Good.
I'll end the meeting. Huh? Okay.
Yes, yes.